So my name is Kristen Angster. I am a senior staff neurotologist at Henry Ford in Detroit, as well as a clinical assistant professor for Wayne State University School of Medicine. Today, we are going to talk about the Petrosal approach, which is a skull-based approach that combines several common neuro-otologic approaches sort of all at the same time. So just to begin, just to kind of give you an idea of where we're going today, this is one of the versions of the Petrosal approach that we'll be discussing today. So this is kind of showing you where we will end up. This is the trans-lab version of the Petrosal approach, which shows access to the petroclival junction, which is kind of the goal for this approach. So before we jump all the way there, let's talk about a little bit of background. So when is this approach necessary and why do we use it? So typically this approach is to access meningiomas, which are the most common intracranial tumor, 35%, and about 10% of CPA tumors. They peak in the 50s and 60s, typically more common in females. They can be caused by low and high dose radiation. They do show aggressive features consistent with malignancy at times. They arise from arachnoid cells. On imaging, commonly we see signs such as hyperostosis, intratumoral calcification, and on histology, we see pneumoma bodies. They are 32% of incidentally discovered tumors, and 32% of them that are discovered incidentally do not grow over 3 years. They do have a malignancy rate of about 1.7% and are found in about 3% of autopsies performed on patients over 50 years old. If they grow more rapidly than expected, one of the differentials would be a hemangiopericytoma. The other common CPA lesions that we talk about are vestibular schwannoma and epidermoid. For diagnostic criteria, there are some specific stains that are used to identify these tumors, and they are graded on a WHO grading scale, most commonly grade 1, though they can be anaplastic or malignant as well. They are managed both medically and surgically, though typically managed surgically is preferred. You can observe them. However, the MRIs are typically done more frequently than for a vestibular schwannoma because the growth is more variable and can be more rapid. After total removal, recurrence is still about 10 to 30%. With subtotal resection, regrowth is about 40 to 60% at year 5. More with some of the more aggressive and higher grade lesions. They can be treated with stereotactic radiation, though we'll talk about why that is somewhat controversial. For tumors less than 3 centimeters, it's typically a low dose, 14 to 16 gray. 90% control has been quoted for WHO grade 1 at 5 years, 50 to 80% with grade 2, 10% of those patients, depending on where the lesion is focused, developing new or progression of neurologic defects. We'll talk about why that's a little controversial and some of the newest data on stereotactic radiation a little bit more later. So specifically for this approach, we're talking about petroclival meningiomas, which is a subgroup based on location. So they're located in the upper 2/3 of the clivus at the petroclival junction, medial to the IAC and posterior to the trigeminal nerve. These account for about 3 to 10% of posterior fossa meningiomas, which account for about 0.15% of all intracranial tumors. The difficulty with these lesions are that the cranial nerves are located between the surgeon and the tumor. They also displace or engulf the basilar artery and its branches, as well as the perforating vasculature to the brainstem. So they're very high risk for surgery. So just a brief case example. This was a patient that I treated with the neurosurgical team earlier this year. And I think her case really highlights kind of every patient's biggest fear when they come to us with kind of vague complaints. This is sort of what everyone worries that they have. So this was a 51-year-old patient who works in a factory downtown. She presented to an outside neurologist with some persistent imbalance symptoms, which were a little bit vague, but persistent for her. And then she noticed that she had occasional dysarthria. And those two together really brought her into the neurologist. She had no significant otologic history on presentation. The neurologist, hearing this combination of symptoms, ordered an MRI. When she came to us, she already had the MRI in hand. This was her audiogram. You can see that she has just a little bit of difference between the word recognition score, but hearing, no red flags there. And unfortunately, her MRI demonstrated the following lesion. So it's not subtle. It's actually surprising that she doesn't have more cranial neuropathies than she presented with. Obviously, this lesion, so she's got an enhancing lesion with significant compression of the brainstem. Her ventricle looks dilated on this imaging as well. On her axial, the lesion is quite large, again, with significant brainstem compression. This is the level of the IAC. You can see on the other side, it's a little hard to see on the left side, but this is sort of what we were faced with. With a lesion in this location, it's obviously very challenging to access surgically. So she was one where the neurosurgeon requested my help to do a Petrosal approach. He felt that due to the size and brainstem compression on this lesion, that to get enough access to get as much out as possible, that it was worth sacrificing hearing, and the patient agreed. Due to her age, gross total resection is preferred over a subtotal resection, and he felt like in order to have the best chance for that, he would need to do the Trans-labyrinthine Petrosal combination. So we'll talk about that a little bit more. In 1988, Dr. El-Mefdi, who's a neurosurgeon, published kind of this landmark article regarding the Petrosal approach for petroclival meningiomas. In his paper, he described 13 patients. All of these papers have pretty low numbers because these tumors are not very common. He reported no mortality, gross total resection in 11 patients. He described the benefits of this approach to be decreased temporal lobe retraction and cerebellar retraction, decreased distance, operative distance to the clivus by 3 centimeters, and the surgeon's line of sight to be in a direct line with the lesion, as well as the anterior and lateral aspects of the brainstem. The way he described the surgery allowed for preservation of the cochlea, vestibule, and facial canal, though this is not always the approach that's used, and we'll talk about that, as well as preservation of the transverse and sigmoid sinus. The vein of Lebet, as well as the basal occipital veins, were preserved. It allowed for multiple axes of dissection and disrupting the tumor's vascular supply early, which leads to decreased bleeding as you're removing the lesion. So this was a more recent paper where they reviewed 109 cases. Again, the number of the tumors they selected to use the Petrosal approach for was very low, but this was the way they kind of divided up how they chose which approach to use. For the Petrosal specifically, they chose it for large tumors with extensive basal attachment, supra and infratentorial extension, and ideally on patients who already had hearing loss. So what is this approach? Why is it controversial? So we're going to go through how the approach is done, as well as some review of just the traditional translab approach, because that is utilized for some versions of the Petrosal approach. So Initially, Dr. El-Mefdi described putting his patient with the head turned away 40 to 60 degrees from the side of the tumor, lowered and tilted to allow the petrous bone to be the highest point in the dissection plane. He does use Mayfield pins, reverse question mark incision, and the temporalis and periosteum are elevated and retracted to the level of the ear canal. At our institution, the opening of the surgical field is typically done by the neurosurgical team before I come into the room. This is how Dr. El-Mefdi described his craniotomy. And so he had four burr holes, 2 on either sides of the transverse sinus, and then resected a portion of craniotomy from the temporal bone as well as the occipital bone above and below the tentorium. So this is what typically things look like once the craniotomy is opened. This shows that the middle fossa has been decompressed. Here's the vein of Lebet. The posterior fossa is also decompressed, and then these are the dural incisions here. And we see our semicircular canals. So before we get all the way there, let's just quickly review our traditional translab approach, just so that everyone joining this lecture feels like we're on the same page and not to make any assumptions. So this is what our translab positioning looks like. Typically, I make my incision about 3 finger breadths behind the postauricular crease and rotate the tissues forwards. We then do our traditional mastoidectomy. This is showing the initial cortical mastoidectomy with Kerner's septum. Again, this is superior, this is posterior, anterior here. Here's our ear canal. We're entering in towards our antrum. We're kind of defining our sinodural angle mastoid tip. Here we're starting to find our sigmoid sinus and our sinodural angle. Further defining sigmoid sinus. Our digastric ridge comes along the mastoid tip, and we use that as a landmark as we start to look for facial. We can start to see our horizontal semicircular canal. We decompress our posterior fossa and ligate any emissary veins that may be coming from the back and causing bleeding. We also decompress the middle fossa here and start to elevate that dura off of the remaining bone in the solid angle. Here we've defined our semicircular canal, so horizontal, posterior, superior is going to be a little deeper. And we've also found incus, which tells us about the level of our facial nerve in the facial recess. Starting to open our horizontal canals. So initially tending to blue line the canals, I tend to open superior first and follow it back to the common crus. I leave that inside border of the horizontal semicircular canal to protect facial along the back wall. This is what it looks like as we start to open semicircular canals. So, drilling down through superior here. And again, with all the canals open, starting to identify vestibule. Once we've got everything widely open, we can follow the canals down to the vestibule and the lymphatic sac and duct coming under the posterior semicircular canal. I'm moving somewhat quickly, so if people have questions, feel free to speak up. Taking out our vestibular neuroepithelium as we go. And then again, kind of identifying facial. I usually don't expose it like this, but you do want to know where it is, and you want to be able to make it clear to the neurosurgeons where that facial nerve is as well. finding the ampulla of the superior semicircular canal, which is a nice landmark for your IAC, then drilling superior and inferior troughs to help identify that internal auditory canal. This is kind of the trajectory of the canal as it's coming in under the semicircular canals. And here, just ligating the endolymphatic duct from the endolymphatic sac as it goes into the operculum, which allows you to elevate that dura, posterior fossa dura, off the remaining bone and kind of more safely drill it away. This is again showing the IAC as it's coming up. Cochlear aqueduct, opening that up can help to decompress some of the CSF and also allow you to free that dura a little bit more easily. And then this shows us our nerves as they come in towards the semicircular canal ampulla, as well as the facial nerve as it makes its genu. These are the superior and inferior troughs with the goal of getting 270 degrees around the IAC. Once you have the IAC exposed, then exposing the actual dura, covering those nerves afterwards and kind of chipping that eggshell thin bone off the top. And that shows the nerves exposed. Again, just a closer look of those nerves as they go from the posterior fossa through the IAC. And of course, things never look this nice intraoperatively, typically. So this shows kind of a labeled example, superior vestibular, inferior vestibular, 7th as it's going up, cochlear aqueduct here, jugular bulb, and then the other cranial nerves as they're coming off. We don't typically see 6 unless we're doing a petrosal approach and have things widely opened, but this gives a nice labeled example of where everything ends up. So that's the trans-lab approach. So adding to that the petrosal extension. So here we see trigeminal. I think this picture is nice because it shows just how close those vascular structures really are, kind of running just underneath where we're working, basilar artery on top of the brainstem, 6th nerve here. We often don't see those structures or think about them as much when we're doing just a traditional translab approach, but everything is quite close to each other once everything's all open and exposed. So you can see how this would allow the neurosurgeon then to look beyond where we've drilled and down into those deeper structures and where the tumor is actually sitting. So this is what the translab and middle fossa approach looks like. So they have opened sort of a middle fossa craniotomy here. This allows visualization beyond trigeminal, beyond the 7-8 complex, into some of these deeper spaces to get to the tumor farther down. They have retracted up the vein of Lebet, which is the primary draining structure for the temporal lobe. We have to be very careful when we're retracting that vein and for how long, because you can cause aphasia as well as memory dysfunction if that vein were to be injured or clotted off. So we are careful and cognizant of that and try to remove that retractor whenever possible and allow that vein to flow. They are also very careful about where they make those dural incisions, again, to help protect that vein. So there are a few variations of the petrosal approach, which I think are also important to talk about. So one of those is known as the retro-lab approach. So if you can see up here for the retro-lab, the semicircular canals have been left intact. This is more of what Dr. El-Mefdi initially described. So superior petrosal sinus is still divided and tentorium is still divided. does allow for a slightly more limited view for the neurosurgeon to some of those deeper structures. So if the tumor was a little smaller or did not have quite as much extension as the example that I showed, the access to the lateral pons and midbrain is a little bit reduced. That mid portion of the CPA visualization can be improved with retractors, but for a slightly smaller tumor, this in a patient with hearing, this may be a preferable approach if the neurosurgeon feels like they can see what they need to see. This is just another view of that retro lab with the retractors, kind of giving a better view. There is also what's known as a partial labyrinthectomy. There have been reports of hearing preservation. So for this one, the superior canal and posterior canal are only partially taken and plugged with wax. Again, this is an attempt to preserve hearing. It only improves the view for the neurosurgeon by a few millimeters. In some cases, that may be enough. But for ours, typically, if we're using this approach, they want as much as they possibly can have to see. This is, again, that translab approach that we talked our way through earlier. And then finally, this is the transcochlear approach. So this is obviously the most extreme version. The problem with this approach and why it's not commonly favored is that the facial has been moved, and so the patient is kind of guaranteed to have a facial nerve weakness once the facial has been moved like this. The facial nerve can partially recover tone, but often with synkinesis. And obviously they lose hearing and vestibular function as well. So it is kind of an extreme version of the approach. So it's often only utilized if the patient already has hearing loss and facial weakness on that side. This picture is just to kind of remind us that real life is never as pretty as the drawings in the textbook. So this is from another paper with a case report where they were trying to propose a classification scheme for petroclival meningiomas. And these are some intraoperative pictures. So here in this picture, this is the temporal lobe, cerebellum is here, Troutman's triangle here. So once they have drilled down, you can see how very quickly things become harder and harder to differentiate in vivo. The field gets very tight and difficult to see. So here, this is the tumor here in these images. So this is that paper. And so I wanted to just briefly describe for you guys some of the controversy that surrounds this approach. So this paper came out in 2020. It is where they tried to come up with a treatment strategy for these petroclival meningiomas. They only use the Petrosal approach for 4.2% of their reported cases. They felt like this approach was ideal for cases with extensive involvement of the skull-base structures, with extension inferior to the IAC and lateral to the petrosal bone, where tentorium is widely invaded. They found that they were only able to get gross total resection in 67.2% with this approach, with a high comorbidity due to brainstem edema, which then limited their ability to do further tumor resection because they felt they needed to get the patient off the table. Due to disadvantages of this approach, including the how complicated the procedure is, how time consuming, and the high risk of complication, they have pivoted to other approaches. There was another report of 18 patients in 2007 with gross total resection in 14. Obviously, as I mentioned, all that had the transcochlear approach had facial nerve injury because that's expected from that version. They shifted their approach towards retrosigmoid or partial petrosectomies without the tentorial splitting, as well as OZ craniotomies with a decrease in facial nerve dysfunction. They advocated for subtotal removal with adjunct radiosurgery and reported a lower morbidity and similar short-term tumor control, but they only followed patients for about 36 months. They concluded that regardless of the approach, progression-free survival rates were excellent over a short-term follow-up period. This paper I found very interesting because I think there were 7 or 8 letters to the editor that followed it, with a lot of arguing back and forth on the paper's conclusions. One of the most interesting, I thought, was from Dr. El-Mefdi, who published that initial landmark article. And he reported, they replied that complete removal of the meningioma, including dura and bone, leads to cure in 90% of patients. They reported that subtotal resection leads to recurrence 100% of the time if you follow patients long enough, and that a lot of these patients die from their disease and not in a long period of time, within 10 years. They also stated that radiation to treat these residual meningiomas has failed for long-term control, 75% experiencing recurrence and 56% with neurological complications. They also said that radiosurgery has increasing concern for increasing failure, but also can lead to aggressive tumor growth after the failure of radiosurgery, and that 15-year survival rate after gamma knife is only 53%, and 70% of those deaths are caused by the tumor. They also stated that they are seeing increasing numbers of patients who've been treated in various centers around the world with subtotal removal and radiosurgery who are now desperate after having undergone multiple surgeries and radiosurgery only for the tumor to grow faster and transform into a higher grade of malignancy. The result is a long course of accumulated morbidity, agony, and expense for palliative management, while the chance for cure is lost because of the failure to attempt or achieve total surgical removal the first time around. So, all of that to say, I don't think it's clear cut. This approach is time consuming, comes with a risk of comorbidities, but it also presents a chance for cure for some patients. So I think when it's utilized for the appropriate patient, it can be a useful tool. But like with every surgery, patient selection is paramount, and proper counseling of the patient of the risks and benefits to this procedure is very important, because it does come with a lot of risks, and the patients need to understand that going in. So I talked really fast, and that pretty much covers what I wanted to say about the Petrosal approach, but I would like to open things for questions or discussion.
Thanks, Dr. Angster. That was great. I had a question kind of along the lines of how to counsel that patient. It's been rare, at least for me, to see these petroclival meningiomas. More common to see vestibular schwannomas, and our typical counseling for small non-growing tumors in young patients is let's just observe. Do you find that in these more difficult scenarios, larger tumors, young patients, dislocation, there's any role for initial observation? Would you ever offer that at the onset, given the, some of the known issues with morbidity after resection?
Yeah, I think that's a really good question. And I think it's a little bit patient specific. So a lot of these patients, by the time we're discussing surgery for them, the tumors are quite large, and they do have some degree of hydrocephalus, which is causing some dysfunction, whether it be imbalance or issues like that. The other issue is, especially for her, she's 51, so the chance of her needing treatment in the future, even if this tumor was not quite as large as hers was, the likelihood of her needing resection in the future is very high. And so, you know, from that standpoint, yes, it is high risk, but she will likely recover better if we do it sooner and before the tumor gets massive. So it is a hard line to toe. And I do think that we as ENT often counsel patients differently than our neurosurgical colleagues in terms of risks and things like that. So it is a very hard conversation to have. And she, you know, really was very anxious, which is totally understandable. She came in with very few deficits. But, you know, I think kind of explaining to her that we're likely going to have to do this at some point, and we'd rather do it before you're found down from hydrocephalus, you know, was kind of where the conversation led. And it is a team-based approach as well.
Thanks. That all makes good sense.
Okay.
All right. Well, I think if there's no more questions, we'll probably call it.
Okay.
That was a great.
Thank you guys for inviting me.
Thank you so much for joining us. Everyone, happy holidays. Take care.
Yeah, you too. Bye-bye.
Thanks.